Hello, everyone. Today, we are discussing something serious, yet extremely important. Nipah virus disease. It's a name that immediately creates concern, and rightly so. In this video, we will walk step by step through what this disease is, how it spreads, why it continues to reappear in India, and what healthcare systems and communities can do to prevent the next outbreak. Let's begin by understanding how this disease first presents itself. Imagine coming down with what feels like a terrible flu, a high fever, a pounding headache, and muscle aches that make it hard to move. That's how Nipah often begins, but it can quickly become much more. Patients may experience violent vomiting, a severe sore throat, and then things can turn neurological. It's a brutal progression, and it's why early recognition is so critical. So, what exactly is Nipah? At its core, it's a severe zoonotic virus, meaning it jumps from animals to humans. Its primary targets? Your brain and your lungs. The scary part is the range. Some people show no symptoms at all, while others develop acute, deadly brain inflammation or rapidly fail to breathe. What makes Nipah a global priority isn't just its high fatality rate, it's its ability to spread, not just from animals, but from person to person, sometimes within the very hospitals meant to heal. This combination puts it among the world's most feared emerging threats. In January 2026, suspected cases, including among healthcare workers, were reported in West Bengal, India. This is significant. West Bengal has seen Nipah before, in 2001 and 2007. This latest event confirms a crucial point. Nipah is not geographically restricted. It's not just a Kerala-only problem anymore. It's a reminder to every clinician across India and neighboring regions. This disease could be in your community. Nipah was first identified during an outbreak in Malaysia and Singapore between 1998 and 1999. Initially, patients presented with encephalitis, brain swelling, and it was mistaken for Japanese encephalitis. The real story unfolded later. The outbreak was linked to pig farms. Fruit bats, the natural carriers, were infecting pigs. The pigs, in turn, acted as amplifying hosts, multiplying the virus and passing it to humans. The virus was named after the Malaysian village, Kampung Sungai Nipah, where it was first isolated. This outbreak taught the world a vital lesson about the role of amplifying hosts in disease spread. Which brings us to the source: the fruit bat. Specifically, species of Pteropus, also known as flying foxes. Here's the key fact: these bats carry the virus without getting sick themselves. They shed it in their saliva, urine, and feces. Spillover to humans happens when we encroach on their habitats, when bat secretions contaminate our food sources, like raw date palm sap or fruit. Ecological disruption brings bats and humans closer. The bats are fine. We are not. Not all outbreaks are the same. In Malaysia, pigs were the critical middleman. But in South Asia, including Bangladesh and India, direct bat-to-human transmission is more common. The presence or absence of these amplifying hosts like pigs changes how an outbreak unfolds. Understanding these pathways is key to predicting and preventing future events. Looking at the global map shows a clear pattern. Malaysia and Singapore had that initial pig-associated outbreak, but in Bangladesh we see almost annual outbreaks since 2001. In India, it's recurrent. West Bengal in 2001, 2007, and now 2026. Kerala in 2018, 2019, 2021, 2023, and 2025. In this region, outbreaks are typically bat-to-human, followed by human-to-human transmission. This isn't a one-time event. It's a pattern of recurrent reemergence. But there is hope, and it comes from Kerala. Kerala provides a powerful learning model. In their 2018 outbreak, The mortality rate was a devastating 91%, but in later outbreaks by 2023 to 2025, that rate dropped to around 30 to 35%. How? Not by a miracle drug, but by preparedness, early suspicion, rapid isolation, prepared ICU care, strict infection control, and trained multidisciplinary teams. This proves that even without a cure, preparedness itself saves lives. So how does it spread? There are three main routes. First, animal to human, from bat-contaminated food. Second, human to human, through close contact with saliva, respiratory droplets, or bodily fluids. And third, the most dangerous amplifier, healthcare-associated transmission. This happens during aerosol-generating procedures without adequate protective equipment. Hospital outbreaks can be catastrophic. Incubation and infectivity. The stealth of this virus is challenging. The typical incubation period is 4 to 14 days, but it can be as long as 45 days. A person can be infectious, especially when they have respiratory symptoms, and we might not even know they're sick yet. Asymptomatic infections also occur. This long, silent window makes contact tracing incredibly difficult and requires prolonged, careful surveillance. Nipah can spread quietly long before we detect it. Once it enters the body through the mouth or nose, the virus replicates locally, enters the bloodstream, and targets the blood vessels themselves, causing vasculitis, inflammation of the vessels. This leads to tiny blood clots, tissue damage, and, finally, invasion of the central nervous system, resulting in encephalitis. This stepwise attack on the vascular and nervous systems explains why patients can deteriorate so rapidly despite our best supportive care. Nipah is not just a brain disease, it's a systemic viral vasculitis. Primarily, it attacks the brain, causing encephalitis, seizures, and coma. Secondarily, it ravages the lungs, leading to severe pneumonia and acute respiratory distress syndrome. It causes cardiovascular instability and can lead to multi-organ dysfunction. We have to think of it as a whole-body assault. The range of illness is broad, from no symptoms at all to a mild fever, to acute fatal encephalitis or respiratory failure. And for some survivors, the battle isn't over. They can experience relapsing or delayed encephalitis weeks or even months later. Many face long-term neurological disabilities. The impact of this virus lingers far beyond the initial infection. For frontline healthcare workers, spotting the red flags early is the difference between life and death. Suspect Nipah when you see acute fever with headache, plus rapidly progressive confusion or altered consciousness, new seizures or sudden respiratory distress, especially if there's a link to a known outbreak area. Early suspicion equals the chance for survival. The symptoms can escalate from dizziness to drowsiness, to coma, to severe pneumonia in a frighteningly short time. This is why clear definitions matter. The WHO classifies cases as suspected, probable, or confirmed. A suspected case is someone with acute fever and a symptom like headache or respiratory distress, plus an epidemiological link, like being in an outbreak area or contact with a case or bats. This framework isn't just paperwork. It determines who gets isolated, tested, and tracked. It prevents both missed cases and panic, guiding a rational response. A probable case is a suspected case with a strong link who dies before lab confirmation. A confirmed case requires lab proof, detecting the virus's RNA by RT-PCR, isolating the virus, or finding specific antibodies. RT-PCR from throat swabs, blood, or CSF is the gold standard early on. But timing is everything. Test too late, and you might miss it. Testing is also a major biosafety event restricted to high-level reference labs. Speaking of safety, Nipah is a risk group 4 pathogen. the highest level. This means handling samples requires extreme caution, BSL-4 labs, triple-layer packaging, and full PPE for collectors. Lab safety isn't just about protecting technicians, it's about protecting the entire healthcare system from an accidental outbreak. On an MRI scan of the brain, Nipah often shows multiple small lesions with a specific pattern. Spinal fluid analysis typically shows signs of viral inflammation. But these are supportive clues, not definitive proof. The critical task for doctors is to rule out other causes of acute encephalitis, from Japanese encephalitis and herpes to cerebral malaria, and even COVID-19. The mantra is, think broad, don't anchor early. Here's the hard truth. There is no proven cure. Our strongest weapon is aggressive, early, supportive care in an ICU. This means controlling seizures, managing brain pressure, providing oxygen or mechanical ventilation, and supporting blood pressure. It's about meticulous, multidisciplinary care to keep the patient stable while their body fights the virus. This supportive care does save lives. There are glimmers of hope in treatment. A monoclonal antibody called M102. 4 has been used compassionately and shows promise. The antiviral remdesivir has been used experimentally. An older drug, ribavirin, has been tried, but evidence remains uncertain. All of these are used under strict ethical and regulatory approval. The search for a definitive treatment continues. This cannot be overstated. Infection prevention and control, or IPC, is your best defense in a hospital. Immediate isolation, contact, and droplet precautions, N95 masks for procedures, dedicated staff and equipment. An IPC failure can seed a catastrophic hospital outbreak. Similarly, rigorous contact tracing, monitoring close contacts for 21 days, is essential to break the chain of transmission in the community. Prevention starts long before the hospital. At the community level, it means awareness, avoiding raw date palm sap, washing fruits thoroughly, and handling sick animals with care. But truly, beating Nipah requires a One Health approach. This means doctors, animal health workers, and environmental experts working together, monitoring bat ecology, surveilling livestock, preserving habitats. We must recognize that human health is inextricably linked to animal and planetary health. For Nipah, One Health isn't an ideal, it's non-negotiable. Let's recap. Nipah is a bat-borne brain-targeting virus with a high fatality rate. Early suspicion and isolation save lives. Diagnosis relies on specialized labs. Treatment is intensive supportive care. Strict IPC and a One Health strategy are our essential tools. And as Carola showed us, preparedness dramatically, definitively reduces mortality. We don't have to be helpless. Thank you for taking the time to learn about Nipah virus disease. This knowledge empowers us all, healthcare professionals, community leaders, and concerned citizens, to be part of the solution. Stay vigilant, stay informed, and let's work together for a healthier future. Take care.